Good evening, Dr.
Good evening, sir.
Good evening, Bhaskar sir.
Ah, good evening, good evening. Yeah, you joined, no? Hello. I will just try to share my screen.
Good evening, sir.
Ah, good evening. Can I share this screen and see?
Yes, sir. You can. Yeah, it's fine.
1 minute. Let me see whether this is the same one.
Yeah, it's perfect.
Yeah. No. I'm trying to see whether this is same which I wanted or something. Yeah. Yeah.
Good evening, Bala sir.
Hello, good evening. Good evening, sir.
Good evening, good evening. How are you?
Absolutely fine, sir.
Good evening, sir.
Yeah, excellent. This is the 12th program, or this is Super 11?
This is probably, I think this session, this is the last program probably.
Okay,
Maybe
okay.
because of elections are coming now.
Okay, okay. SP sir, good evening. Bhaskar sir, good evening.
Good evening.
Good evening, sir. Prabhas, Balivan sir, good evening.
Good evening, sir.
Bhaskar sir, is this the one that we discussed in Bangalore during the launch of your leadership program? The same one, or it's a new? Bhaskar Tanasha?
స్టేట్ సెక్రటరీ చేద్దామని చూస్తున్నాను. స్టేట్ సెక్రటరీ ఆగి ఉంది అసలు. అది ప్రాబ్లం.
Darar sir, good evening, sir.
Good evening.
Nandini ma'am, good evening.
Good evening, Amy. Good evening, Darura sir.
Hello, madam. Hello. Welcome.
Thank you, sir. Good evening, Manish sir.
Good evening, ma'am.
Ramkrishnan sir.
Good evening, ma'am. Good evening.
Good evening, sir.
Ramkrishnan
evening,
sir,
ma'am.
good evening, sir.
Good evening all.
Good evening, all.
Ranganath, Dr. Ranganath, good evening.
Yeah, good evening. Good evening, sir.
Good evening.
Sir.
Good evening, Dr. Bhaskar Shinai, sir.
Good evening, sir. Good evening, everyone. Good evening.
Good evening, sir.
Bhaskar
Good
sir,
evening.
good evening.
Good
Good
evening, sir.
evening.
Sir,
Good evening,
Bhaskar
madam.
Sinha,
How are
sir.
you?
Good evening. Fine, sir.
Nice to see all of you.
Yes, sir.
Again, after the Coimbatore research.
Where is Chetan?
Chetan is too busy.
Call
Too busy
Manish,
making
call him.
all arrangements.
Hello, sir.
Multifaceted activity.
Oh,
Hi.
think
See,
of
I
the
am telling
angel.
Dr. Chetan is too busy. I am telling others.
Think
Yeah,
of the angel, and here he is.
yeah. Usually it is used for the devil.
That's how you take
Jaideep
it.
sir, good evening.
Yeah, good evening.
sir.
I think it's 9 o'clock. We should start it.
Yes.
K. Ghosh madam,
Good
good
evening,
evening.
Yeah.
Dr. Taral
Yeah.
Dalal Taral Nagda.
He's there. He's
Sure.
there.
Thank you.
Dr.
Welcome.
Taral, you can rename yourself, please. Okay. So, good evening, all. Welcome to another link of Super 11. That we know that it is the every last Thursday of the month we are having this Super 11, and you know that this is a brainchild of the brainy person. That is Dr. Bala Subramaniam sir. So he is very much there and he is fully involved into this whole activity. So thank you, sir, for this guiding us for this all the whole series. And thank you all the faculties. Till now we have almost 7 Super 11. So almost 35 faculties have participated in this. And this is another episode, that is link 8. And today, bone and joint infections. And for that we have a wonderful moderator like Dr. Bhaskar Shenoy, and of course equally a knowledgeable panel that is in form of Dr. Balivant. He is ID expert. Welcome, Dr. Balivant. Dr. Prabhas Prusungiri. Welcome, Dr. Prabhas. And Dr. Manish Mehta, another ID expert. And because it is a bone and joint infection, we have Dr. Taral Nagda, who is the Pune-based pediatric orthopedic surgeon, and he's been known for his practical tips about bone and orthopedic problems. So welcome, Dr. Taral. First, I will request, I think Dr. Vasant is in a flight, so it's our pleasure to welcome Dr. Vasant Kalatkar, President-elect, and past chairperson of ID chapter. Dr. Vasant, will you bless the audience first? Unmute, sir.
Good evening, all. Dear all friends. Actually, I'm going to that neuro pedicon that's for Goa. So on way I'm in flight. I wish all the best and let's continue this activity for Vida. This is great. It's great going on. Let's hope it will reach the highest point in Vida. I'm really sorry because there's so many noises are there, and let us go ahead learning together. Thank you.
Thank you, Dr. Vasant. That's why I call you first, because otherwise it's a prerogative of Dr. Rangnath Darur sir. Chairperson, ID chapter. Sir, please welcome the house.
PIDA is very, very active with the blessings of Vasant Kaletkar, who is my predecessor. And all the seniors have promised support once I have taken over the charge as chairperson. The result is now you have academic activities which are mainly based on evidence, plus that lateral thinking of our seniors, how to improve, how to make the people attract and continue our endeavor of teaching and learning process. This is the result of our efforts and our senior people's guidance. So we have discussed so many. Today's topic is bones and joints, infection of bone and joint. So this is a little bit of far away for all the pediatricians and who have not practically worked in general hospitals. This will be highlight and our approach will change. But I worked in Singareni Collieries, which is full of accidents and bone and joint diseases. So first 2 years of my life, I started in 1980 to 82. I was in orthopedics department and trying to learn, which I learned has given me enough of experience in handling the osteomyelitis and joint infections. With that base, I am very much interested in this session and I'll be actively following the discussions, and if needed, I will try to learn from you. Thank you, and over to Chetan to start the program.
Yeah, thank you so much, sir, for the blessings. And I will just acknowledge the presence of Dr. Bala sir, Dr. Vijay Yevle sir, Dr. Jaideep Chaudhary, Dr. Kheya Ghosh, our EBs and treasurer, Dr. Neminathan and Dr. Yashwant Rao, Dr. Janani ma'am, Dr. Nandani, Dr. Jalil, and all respected people on the screen. So now I'll request Dr. Bhaskar to take over, and you may go ahead with a brief introduction of your panelist as well as subject. Thank you so much. Over to you, Dr. Bhaskar.
Thank you, Dr. Darur and Chetan, for giving me an opportunity. Of course, with the short notice, we could do all those things. And respected Bala sir and Vijay Yevle and Jaideep and all the seniors, it is a honor and pleasure today. And we have our very good panel, Dr. Balivan, who is my colleague in Manipal Hospital, Dr. Prabhas Pasangiri, who is a well-known intensivist from Kolkata Institute of Child Health, and Dr. Manish Mehta from Ahmedabad, active member of PIDA, and Dr. Taral Nagda. In fact, I had the privilege of participating with him in one of the CMEs some time back. Hope he remembers. And it was extremely well-conducted program. I learned a lot from him. And today it is my pleasure to welcome you, sir, for this program, which is based on bone and joint infection. Without wasting much time, let us directly go to the session. I'll share my screen. So osteoarticular infections are fairly common, but frequently underdiagnosed. There are much data is very less regarding the incidence, and most of them are these frequently affect children younger than 5 years, and the bones and joints of lower extremities are more affected compared to the upper extremities. And then the delayed diagnosis, improper management, that leads to complications and poor outcome. If you classify it as native infections and orthopedic device related infections, of course, we are not dealing much with that part. The one which we generally see is osteomyelitis, septic arthritis, and sometimes infectious spondylodiscitis. And it can affect all ages, of course, but the importance is that the cartilage damage can occur within 8 hours after the infection and can result in damage to the bones. And most of the symptoms may mimic other common infections or inflammations. And that's why there may be delay in the diagnosis. And sometimes you may be confused with the diagnosis. And that can lead to irreversible bone destruction and lot of other complications. So with that brief introduction, let us go through the cases. The first case, 1 year, 6 months old, previously well developmentally normal, fever of 2 weeks, swelling in the left hip for 2 weeks with pain, and he is not bearing the weight. There is no history of trauma or viral illness or IM injections. Amoxiclav and cefixime were given for 6 days. His left leg was flexed at hip and knee. A range of movements were painful and other things are fine. So, Dr. Balivant, I would like to ask, with this presentation, what is your clinical impression and what are the things that you try to think of?
Yes, sir. Actually, in this scenario, we have to think about whether it is a infective focus or it is a kind of a non-infective focus. In the infective focus, it is the acute infection or any reactive infection. For example, septic arthritis or osteomyelitis can present like this. At the same time, transient synovitis also can present like this. And non-infective conditions like juvenile rheumatoid arthritis and Perthes disease. Perthes disease usually 3 and beyond the age, but still that could be the differential diagnosis. But the last differential could be the malignant one. These are the differential we have to keep in mind at this point.
So you told there is it could be some of the bone and joint infection. So what clinical presentation generally you will evaluate for bone and joint infection? What are the clinical presentations that make you think of septic arthritis or osteomyelitis?
Generally, children's, those who have a focus in the joints, at the time there will be a restriction in the joint movement. The bigger children, they comes with the limping. And sometimes the small babies, where they are not weight bearing, whenever we are changing the diaper, at the time they cry with the pain. The paucity of the movements will be there in the joints. We call it a pseudo paralysis. And sometimes when we are culturing the staphylococcal, the bacteremia, what it mentioned like that, we have to rule out the bone and joint infection because the septic emboli can go and seed in the metaphyseal end arteries and it can produce the osteomyelitis. And any penetrating trauma, we should suspect about bone and joint infection. And also kind of a bleeding disorder, hemophilia, followed by a child present with a swelling joint along with the fever, we have to think about the bone and joint infection.
Absolutely. That is one crucial point wherein bleeding disorder who has developed some fever, you may have to think. So, Dr. Manish, what are the, when you think of bone and joint infection, what are the initial investigations you try to do it?
Yes, sir. So here basically we are suspecting mainly infectious, probably second possibly inflammatory condition. So we'll just do basic investigation like CBC, CRP, ESR. But the most important investigation will be the culture. Blood culture will be the initial investigation before starting any line of treatment or antibiotics. And if possible, if later on we are going to aspirate this joint, then obviously fluid, synovial fluid will also send for the culture and routine examination. CRP and ESR initially may be very non-specific for any inflammatory condition, but their role will be more helpful when you are treating the patient and to see the response to the treatment. CRP will be more helpful in these type of conditions. And obviously, isolation of microorganism is must. At least we should try our best to isolate the microorganism to guide our further treatment. When initially we start usually with the broad spectrum antibiotic according to the age and suspected organism, but later on it will help to narrow our spectrum and antibiotic stewardship thing.
So what about the procalcitonin? When you do CRP, can you not do procalcitonin?
Sir, it's a more of fancy investigation in such patient. It may help sometimes when initially CRP may be negative, but not very much helpful as such in a clinical scenario, in this type of clinical scenario where things are quite obvious on examination as well as in routine investigation.
In fact, when it comes to procalcitonin, there are not much of data to say that it helps in the infection in the bone and joint. So it is mainly the CRP which is likely to help both as a prognostic and the initial value. So when you come to the diagnosis, it is the detection of pathogen, or we look at the detection of the host response. And in the pathogen, as he told, even the molecular diagnosis, in addition to culture, we can do. And host response, you can do the radiological, histology, synovial fluid analysis, and the biomarkers. Okay. So this child in the initial investigations, total count was 27,000 with the neutrophil of 46 and HB 9.6 and SCRP quite high, 192 milligrams per liter. And this is the X-ray, but the initial X-ray didn't show much changes. Dr. Taral, in this situation, you have strong suspicion of bone and joint infection or the septic arthritis. What other investigations you would like to do, and what are the pros and cons of these investigations? Can you just highlight?
Yeah, there are. I just want to highlight 2 points. That is something known as Cocker's criteria, which includes difficulty in weight bearing or loss of function of the joint, then presence of fever, high ESR, and leukocytosis. And to this we add the 5th criteria, which is CRP. In this child, all 5 are positive. So there is no doubt that we are dealing with bone and joint infection unless proven otherwise. So whenever you have a limb pain with fever or some other symptom, the diagnosis should be bone and joint infection unless proven otherwise. We should not depend on a lab investigation or a culture that we give antibiotic, prove the infection, and then refer to orthopedic surgeon. That should not be the sequence of events. So this is what I want to suggest.
Yes,
the
sir.
choice of radiological investigation, it's always X-ray first, because it's the easiest to do in a clinical setting, and it can rule out an osteomyelitis. That's the first X-ray to be done. If I am in a hospital setting, we do a combination of ultrasound and an MRI, because both will require sedation in a small child. So we do an ultrasound first to look at the joint swelling. A good sonologist can differentiate between effusion, which is resulting from inflammatory synovitis, versus exudate, which is resulting from an infective pathology. So a good sonologist can give you indication that this is septic, and this is not just a pure simple effusion of the joints. But today, I think it's important to distinguish between synovitis or infective arthritis and osteomyelitis. And if it's possible, MRI is a gold standard. And when you do MRI, it's also important that you ask the MRI doctor, the radiologist, to scan the adjacent joints and the opposite joint so that we don't miss multifocal lesions.
So, yeah, you told you will do MRI and ultrasound. Why not directly MRI if you are planning for MRI? That's the question.
Yeah, so the reason is by the time MRI is prepared and it's available, it takes time. Most of the time, if you are in an institution, MRI is easy to do. But even in most of the children's hospital, you won't have MRI in the institution, whereas ultrasound will be present in the hospital. So if the ultrasound shows significant effusion or a sepsis, I can do an aspirate under ultrasound, then start patient on an IV line, and then send him for MRI. So at least you have an immediate sample available, for to process. So ultrasound is the first investigation.
Whatever the CT scan, suppose if ultrasound is the MRI is not available in smaller center, will CT scan help you?
No. CT scan has no role in acute bone and joint infection.
Yeah. So the point well taken. X-ray may be initially normal, especially within first 2 weeks of symptom onset. It is said that it is normal. By the time you see some X-ray changes, osteolytic changes, or periosteal elevation, it may be up to 2 to 3 weeks. And ultrasound, as he told, has a high sensitivity for joint effusion. Septic arthritis, it will more helpful. And what about in osteomyelitis? Will it help, sir?
Not much. It will not.
Ultrasound in
Ultrasound,
osteomyelitis.
yeah, it will not help because the sound waves cannot penetrate bone tissue. And
Yes,
that's
yes.
the reason they cannot pick up anything which is happening inside the bone. So you need an MRI.
No. So CT, as he told, of course, it is not very helpful. MRI is the gold standard. So having said that, we went ahead, as you told, ultrasound hip was done, joint effusion with thickening of the capsule, and MRI hip shows large hip joint effusion with altered signal intensity with the left iliac and adjacent acetabulum. Manto was negative. So how will you proceed, Dr. Prabhas?
So as we have confirmed the diagnosis of septic arthritis of this patient, there is a large joint effusion. So there should be the two goals of this management. Number one is to whether we can isolate the organism. Number two is the appropriate antibiotic therapy. And number three, the involvement of the pediatric orthopedician, whether we need a surgery or not. So for diagnosis of the organism, the blood culture is gold standard, as well as the aspiration of the joint that can be done usually under by the USG guidance by our orthopedic colleagues. And depending on the therapy we need to give, definitely we need to start IV antibiotics. There is no
I
role
will
of...
come to that. Before that, just let me know, what are the common organisms that usually are seen in...
definitely the first organism is the Staph aureus, that is prevalent in all the ages group. There may be MSSA, there may be MRSA. The MRSA cases are being increased. Even in our hospitals, we are getting more and more MRSA cases. Infants, small neonates less than 3 months of age, the gram-negative organism like E. coli, Klebsiella are more common. Pseudomonas, strep pneumoniae, Hib, and Salmonella are less frequently seen, and except in few cases of sickle cell who developed these cases, they can develop Salmonella or Pseudomonas. And definitely the number 5 is the Kingella kingi that can present a different way, but that's a very much important organism for osteomyelitis and septic arthritis in a younger kid.
Yeah. So, sir, Dr. Taral, have you seen Kingella kingi isolated in our context?
No, not in India, not a single case.
Yeah. They say that in Western literature, if you look at the incidence of Kingella kingi is quite high. In some studies, it is about 40 to 50% also, they say Kingella kingi. But in India, it is not there. Either we are not isolating, or what the literature says is that you should directly inoculate the synovial fluid into the culture medium on the OT table itself. That can improve the yield or outcome of that Kingella kingi. So I will not go into the details, but literature says that it may be there in India, but probably we are not isolating. So these are the various risk factors which he has told. So Prabhas, again, you were talking about the initial therapy. So what are the initial empiric therapy that you start? Because now, see, the culture will take some time. You cannot wait for the culture. So how do you go ahead?
So depending upon the condition of the patient, we need to start the therapy. As I told earlier, there is no role of oral antibiotic. You must have to give the IV antibiotic. So depending upon the local sensitivity pattern, local epidemiology, and the status of the kid. If there is a smaller kid, infant, less than 6 months old, extremely sick, has some features of septicemia, bloodstream infections, blood culture already flagged, ICU candidate, disseminated infections, then the aggressive treatment should be done. So the full therapy for Staphylococcus aureus should be given. So in that case, if you are suspecting or if you are isolating MRSA frequently, is it more than 20% or 30% of Staphylococcus aureus isolates, then you have to start both the MRSA and MSSA coverage. For MRSA, it is drug of choice of vancomycin, and MSSA is oxacillin or flucloxacillin or cefazolin. At the same time, we need to give a third generation cephalosporin, that is ceftriaxone, ceftazidime, or cefuroxime. So smaller kid, sick kid, you have to start with MSSA, MRSA, and a third generation cephalosporin. But if you have a less numbers of MRSA isolates in your hospital, and the kid is not that much sick, a bit older, then you can start with the third generation cephalosporin with only MSSA coverage. But we need to search for the organism. If you are getting MRSA, then you have to switch up the therapy from MSSA to MRSA.
Yeah. So as you rightly told us, Staph aureus, whether MRSA or MSSA. Depending on that, you should continue the start the treatment, and empiric treatment between 3 months to 5 years also. Cefuroxime also covers MSSA, Kingella kingae, pneumococcus, and Hib. Cefazolin covers first 3, but not Hib. And the antistaphylococcal penicillin, it doesn't cover Hib and pneumococcus, of course, Kingella kingae. Balivant, when it comes to the neonate, how do you do a selection?
In neonate, actually, clinical identification also very difficult because there won't be any focal signs, and sometimes they present with the refuse to feeding and the fever of unknown origin like that. And antibiotic wise, neonates usually have both gram-negative and gram-positive infections. Especially the resistant infection is quite common in the neonates. For example, multi-drug resistant E. coli and Klebsiella, Pseudomonas, those type of infections, and MRSA. So this is very common. Even Candida like fungal infection also quite common in the extreme premature baby who are on the NICU. So empirical therapy usually should cover in a sick neonate both gram-positive and gram-negative coverage. Initially, we can go with the kind of a gram-negative like carbapenem, or based on the local antibiotic pattern, or BL-BLA combinations like piperacillin tazobactam, along with the vancomycin.
Manish, then once you get a definitive treatment, how will you do the definitive treatment?
So basically, sir, it depends which organism we have isolated, what is susceptibility pattern, what is your local epidemiology, and whichever drug we choose, how much bone penetration it has. Cost factor we also have to see, because we are going to use this antibiotic for the wrong time, and there is contaminant septicemia or bacteremia is there or not. If it is there is associated bacteremia or septicemia, you need to treat it very hard. So according to these factors, we'll decide our treatment. But yes, to start with, is always it is IV, and then later on when condition stabilizes, it goes to oral.
So we started on ceftriaxone and clindamycin. Left hip arthrotomy was done. Pus was drained. Iliac bone was curated and sent for HPE. Gram stain AFP negative, gene expert negative, culture no growth, histopathology acute suppuration, suppurative inflammation, no granuloma. Now, how will you do the choice at discharge? See, sometimes before that, I would like to ask question. There are not that, though we say the culture has to be done, and most of the times, either you will have a case who has been already treated with antibiotic, or you may not be able to isolate some organism in all the cases. So most of them are what is called as a culture negative bone and joint infection. So in such situation, how will you go about?
So basically, it depends on the clinical condition of the child. If it is a critical child with septicemia and bacteremia, you have to treat very hard, especially in the young infants and newborns. So you have to start with a broad spectrum antibiotic like either BL-BLI combination or carbapenem with vancomycin or teicoplanin. After 40 to 72 hours, if you get something in the culture, you can de-escalate your line of treatment according to the organism. If you don't get anything, if child is improving, then probably you have to continue with the same line of treatment, or you have to try to get organism from somewhere else, maybe some other pathogenic infection somewhere else in the body, some abscess is there in the body, then you have to try to get pus from there and to try to get organism isolated from there. So you have to try hard to get the organism, but if your child has responded to this treatment, then you have to continue with the same line of treatment.
So that means if the child improves with whatever your empiric treatment, you continue. If it is not improving, make an attempt to do further tests and find out whether you can get some better this thing. So now you have a lot of the molecular diagnosis panels. Giri, are you using this? And this question goes to Dr. Taral also. Are you using this? Do you think this has to be done? Or are you doing that?
Actually, we are doing lots of biofire panels like upper respiratory biofire, lower respiratory CSF.
When it comes to bone and joint.
But we are not doing this bone and joint because actually the cases are not so frequent, and sometimes we are not getting samples. So we are not actually doing this. But I just want to highlight one thing that about the septic arthritis. So it may affect different joints. The commonest, I think, in the hip or knee regions. So do you need to go for an arthrotomy for each and every cases? I need a discussion from Dr. Tarun.
Yeah.
Or
So
just
I'll
get on
Yeah.
send the path or the
so I'll
decompress.
answer both these questions. First of all, it's very important, since there are a lot of in ID specialists here, to isolate the organism and get the culture sensitivity of, if possible. Now, most of the time we found that if an orthopedic surgeon is doing aspiration or arthrotomy, he would collect a sample, it goes into a bulb, is kept in the fridge, and next day the microbiology will process it. So that is where you are killing all your chances to get a positive isolate. So what do we do nowadays is to ask for a blood culture bottle in the operation theater. And whatever tissue we get, we directly inoculate it into a blood culture bottle, so that the chance of us getting a positive culture becomes very high. So, whenever any one of you who are on the panel or those who are watching this program, if you have a child with suspected bone and joint infection, and if a general or a pediatric orthopedic surgeon is going to do aspiration or arthrotomy, insist that they inoculate the material in the operation theater. Okay, that's something important. We
That's
also
a
know
very good,
nowadays.
sir. That is a very good point, because I also
Yes,
wanted to tell
absolutely.
that we should have the practice of inoculating, because there is so much literature which says that the yield is much better with
Yes.
this method.
And the simplest thing is a blood culture bottle, because it is available in all the hospitals everywhere. Okay.
Yes,
So the
absolutely.
second point, which has been proven now, is a previous antibiotic use or abuse does not affect your yield. So if the child has been given an antibiotic and then somehow the arthrotomy or aspiration is done later on, that does not matter. That is no. And thirdly, what I want to see is we do use molecular diagnosis, because it's quicker. You don't have to wait for 2 to 3 days to find out that this was MRS. And lastly, I want to see, because the whole approach now with with our ID colleagues with antibiotic treatment of bone and joint infection is to hit hard, and then reduce the antibiotic if the culture proves that an easier or a less potent antibiotic is effective. Then you reduce it, but you don't start with a smaller antibiotic and don't then go higher. Now, as far as Prabhas's question, arthrotomy and aspiration, you must get a sample, that has been indicated. And this in shoulder and knee, you don't have to do an arthrotomy. Aspiration and lavage with needles is sufficient, which can be done under sedation. But in a joint like hip, it has been taught that arthrotomy is essential. But nowadays, we can treat a lot of septic arthritis of hip just with an arthroscopy. You don't need a big incision. You can do an arthroscopic lavage. And arthroscopy also allows you to get a synovial tissue. And it has been also proven now that synovial tissue, when sent for culture, has better yield than a synovial fluid, which is sent for culture. So there are few changes, which have clarified our approach to bone and joint infection. And I hope this discussion has summarized it.
Yes, thank you, sir. Thank you for that inputs. So then, would you like to continue, Balivant, parenteral antibiotic? Say there was a time when we used to continue 3 weeks, 4 weeks, IV only with great difficulty. Now there is a switch. So when can you switch over to oral? Because it should be a safe time that you should try to switch. Balivant.
Yeah. See, the oral switch has to be decided by how the baby is responding to the parental antibiotic. In the parental antibiotic, the child remains afebrile at least more than 24 hours. Usually it happens 2 to 3 days to maximum 5 days. So the child is afebrile for more than 24 hours. And the signs and symptoms, how the child presented with, is resolving. And there is no further any complications. And laboratory features also has to show some improvement. For example, if you do the CRP, from the peak of the CRP itself, at least a 30 to 50% of a reduction in the CRP. By combining all clinical and laboratory features, then we can decide we can switch over to the oral antibiotic.
Manish, what should be, how long you will try to treat, the duration of treatment?
So they have roughly guideline for the duration of treatment. Actually, depends on the type of organism, what are the host factors, what is the age of the child, whether there are associated complication like there is local abscess or soft tissue involvement, or there are in peripheral pyemic spread of the infection is there or not, and local, as Taral sir has said, whether arthrotomy or scopy has been done and local pus has been removed or not. All these factors, based on all these factors, will decide the duration of treatment. But roughly, if we say uncomplicated septic arthritis usually requires 2 to 3 weeks of treatment, and same about osteomyelitis, around 3 to 4 weeks of treatment. The conditions which require prolonged treatment are mainly MRSA, which may require 8 to 10 weeks, and sometimes fungal septic arthritis, which may require treatment up to the 6 months. So complicated infections, MRSA and fungal will require prolonged treatment. Otherwise, 2 to 3 weeks would be enough for uncomplicated cases.
Yeah, then when do you, yeah, as you told, these are the situations wherein you recommend a prolonged treatment, infant or MRSA or a delayed response, or those who have complications. Generally, they will be given prolonged treatment. Okay. Now, the follow-up X-ray. This is the follow-up X-ray. The child was fine. Sir, any comments,
Yeah,
Dr.
yeah.
Taral?
So, this X-ray very well shows that there was a iliac involvement, but it also showed that there was a proximal femoral involvement. You can see some lytic areas. But I want to comment that this has been treated well. The joint space is good. The physis, the growth plate of the proximal femoral epiphysis looks absolutely pristine. And this is a good outcome of this difficult problem.
Yeah, yeah. Thank you, sir. So let us move to the next case. 9-year-old, short febrile illness. He had a dengue proved, and he was admitted in a hospital outside. Persistent fever spikes. He was transferred to another hospital. He had thrombophlebitis, right hand. Then high-grade fever spikes continuing. Started on piperacillin tazobactam after blood cultures. And these are the investigations with the CRP of 96, total count of 24,000, with a mild elevation of the liver enzymes. Then what would be the empirical choice at this stage, Manish?
Yes, sir. So as we discussed previously, this is probably either we are suspecting some MRSA infection or gram-negative infection as child was hospitalized. So probably we have to give higher antibiotics because this is most probably hospital-acquired infection. So it's going to be a resistant organism. So vancomycin with BL-BLI combination will be the ideal combination for this kind of patient.
So now the report comes. This is the report, vancomycin sensitive. And the stopped piperacillin and continued with the vanco. Fever persisted, blood culture no growth, developed the left knee swelling with the restricted joint movements, even after 4 days of vancomycin. So what are your thoughts? Would you suspect osteomyelitis in this case?
So basically, any patient who is expected to improve with sensitive antibiotic and not improving, that means either there is some associated complication. First, you have to check whether a drug is properly going or not, dosage of the drug, schedule of the drug has to be checked, whether it is properly administered or not. And after that, all these things, if it is everything is secure, then we have to see whether there are any associated complication or there is some distant focal involvement is there or not. So osteomyelitis as well as some distal involvement of any other joint has to be thought of at this stage.
Yeah. What is your thought, Dr. Talal?
So the pathophysiology of bone and joint infection with respect to the what does the organism does to our body and how does our body behave to curtail that infection is very well studied now. And we understand that the barrier which body makes, the organism is trying to break that and go away. So what I want to say that in this case, the best time to fight the organism has been lost. In a way that when the child had fever and developed a hand infection, instead of doing just a blood culture and starting antibiotic, they should have involved an orthopedic surgeon, got an investigation done, and drained that source of infection. Because the antibiotic also to reach and alter the natural history, it takes time. So that time was lost, and in that thing, though the sensitive antibiotic was given, the organism had already disseminated.
Oh.
And organisms are more intelligent than the clinicians, and then they do survive well in difficult organisms. But this is now a disseminated infection. It can travel anywhere. It can go to the heart, it can go to kidney, it can go to any organ, and one has to be very, very aggressive in treating this.
Yeah. So the repeat investigation counts were 18,000 with a CRP of 120, and then MRI, left knee septic arthritis with the proximal tibial osteomyelitis. Arthrotomy done, and 5 ml of pus was drained. So this is a point that all should undergo fluid cultures we have already discussed. So synovial fluid analysis, Dr. Taral has already given the tips which I have put here. And this is a beautiful article enhancing the diagnostics in orthopedic infections. In detail, all the things are given here. So again,
one of the important pointer for this case is that the infection, the first focus in the dorsum of the hand, then the knee joint. So if you're suspecting staph in this case, as there's a disseminated infection, most probably hematogenous disseminations, so it should be very high suspicion of MRSA from initial.
No. Thank you. So this question goes to again Taral. Indication for surgical interventions in acute osteomyelitis. What is the time? Do you interfere with all cases or the particular group of patients where they need interventions?
Right. So now we know that the infection starts as osteitis, which is similar to cellulitis in soft tissue. And then you will have formation of abscesses in the bone. Then you have subperiosteal abscesses and then intramuscular abscesses. That is how it disseminates. So in the stage where on MRI has made the decision making very simple. On MRI, if you see osteitis, which means signal changes in the marrow, but no abscesses, then that is the stage when you can treat with antibiotic alone. Okay, there is a role for doing a needle-guided bone culture in those cases, but you don't need to do an operation in those cases. So then you obtain your sample for culture and histopathology, you decompress that, but you don't have to operate. Moment you see abscesses within the bone, that's the best time to operate because you will be able to treat the osteomyelitis now completely without any sequelae. By the time the subperiosteal abscesses form, of course, you have to do surgery and decompress that, but we know that we have already made a part of bone avascular. The real worry in osteomyelitis is damage to the bone because of the vascular involvement, which happens because of subperiosteal abscesses, which deprive bone of the blood vessel, and one needs to act before that, ideally. So the indication for surgery in a case of acute osteomyelitis is any osteomyelitis child which is beyond the stage of osteitis. They will all need surgery. In our country and our situation, by the time the patient reaches a pediatrician or a bone and an orthopedic surgeon or an ID specialist, it is already beyond the stage of osteitis. And hence, I would say most of them require at least a consultation with an orthopedic or a pediatric orthopedic surgeon, and if he feels an early intervention.
Yeah, the luxury of having a pediatric orthopedician may not be there in all the places. Of course, some metro centers and this thing, but of course,
I just want to give one suggestion. Like ID specialists are not there everywhere, but a pediatrician in a second-rank city or a rural area can now avail consultation from an ID specialist online, and that he can guide them to treatment. Similarly, we do guide general orthopedic surgeons, and a lot of them call us up and say, sir, in this situation, what to do? And we can remotely guide them to a more effective treatment. That is possible.
Oh, excellent, excellent. So fever spike after this abscess was drained, it came down, and the persistent fever spikes. Sometimes we may have to look at, as they told, the dose and compliance resistant organisms are some complications, sequestrum, subperiosteal abscess, all those things we have to take care. And there is if it is still not there, we may have to look beyond the infection. So having said that, the CBC was normal. Workup for CRP came down to 41, and all the other investigations for immunodeficiency and other things were normal. After 2 days, the thrombophlebitis in left dorsum evolved into abscess, which required IND, and pus from both grew MRSA, and fever settled 7 days post procedure. So these are the few points that we took. What I mean to say is, as he told, there may be multiple foci, and the infection must have spread one thing, and we have to look for other focus of infections whenever there is one, especially when you suspect conditions like MRSA or MSSA. So not that every time when you start treatment, you are seeing the typical textbook description of the response. Sometimes the failure of therapy may be there. So Dr. Balivant, when should you consider the treatment as failure of therapy, and what are the common causes? When do you see that every time you don't see a proper description wherein you get a positive response?
Yeah. So initially we discussed a kind of an uncomplicated bone and joint infection has to respond within 3 to 5 days of IV antibiotic. Suppose the child not showing any clinical improvement, the child have a persistent fever and along with the swelling persist, erythema persist, then there is no clinical improvement after 3 days, it could be considered as one of the failures. Same like the child initially looks like improved, again the symptoms reappears. So that is also one of the criteria for the failure of this therapy. Then other parameters like inflammatory markers is not at all coming down, like WBC counts or CRP. After 1 week of effective therapy with the adequate dose, still it's not coming down. Then there is a possibility of the treatment failure. Then the child have any pathological fracture, that could be the reason.
Yeah. So having said that, we will go to the next case because time is almost there. So 12-year-old, previously normal, pain in the middle of the back, 2 months, weight loss, and there is no history of contact with the TB, and no lymph nodes, no joint swellings, and gibbous present in the upper back with the tenderness in the paraspinal region. These are the investigations, Manto 23. Otherwise, everything is okay. What is the likely diagnosis, Dr. Manish?
Yes, sir. So here is the insidious
And
onset
this
of
is the
infection.
X-ray which is taken. Yeah.
Yeah. So it's an insidious onset of the disease, very slowly progressive, not like presently like with our previous case, like septic arteries, very high fever or something like that. But here there is a gradual weight loss and gradual, somewhat we say, gibbous formation. So some destruction of the vertebrae is there. And in X-ray, if you see, there are some paraspinal shadows. So here, possibility of some chronic infection like tuberculosis in our country should be thought of first at this stage because of the slow growing infection.
Dr. Your comment about the X-ray?
Yeah, so there is a paraspinal abscess or a paraspinal shadow. On a lateral X-ray, things will become more clear. MRI things will become still more clear. But I want to again say that though in our country we say that tuberculosis will be the most common diagnosis, nature throws googly at us, and many times this can be eosinophilic granuloma, this can be lymphoma, sometimes it can be brucellosis. We have seen cases of brucellosis in children in India. So it is a dictum that that once this should be investigated, and nowadays it's very easy to do a CT guided biopsy and culture. So when I say every specimen which is sent for culture should be sent for histopath, and whenever you are suspecting tumor and sending for histopath also should be culture.
And the radiologist gave the thing that, I mean, may not be very clear in this X-ray. There is a collapse of T6. And of course, this is the MRI. Sir, your comment on MRI.
Yeah. So, this is typically showing a single vertebral lesion, vertebral collapse. On the soft tissue side, we have massive paraspinal abscesses. There is also paravertebral, there is a posterior soft tissue which is causing compression on the spine. And we see that there is a deformity in form of a kyphosis. So again, the first diagnosis will be tuberculosis, but this should be subjected to a CT-guided biopsy and culture, which can be easily obtained from the abscess or the soft tissue.
So the gene expert detected the MTB, rifampicin sensitive, treated with the NTT and steroids, and the child improved very well. So this is the message is that as Dr. Talal, he told that TB is the first thing we have to think of, but TB mimics also we have to keep in mind. Brucellosis is one of the TB mimics. It can come with abscesses and similar pictures in some cases. So let us go to the next case. 9-year-old, pain in her right ankle and spine, left knee, hip, and both feet were painful. These symptoms were not constant, and 4 months it went on. All the investigations, including the immunological and other things, were normal. X-ray, spine and chest were normal. MRI, spine and pelvis revealed multiple inflammatory lesions of thoracic vertebrae and sacral vertebrae, treated as osteomyelitis, but no relief. So it was referred. Now, here there are 2 X-rays, Dr. Taral, again for you, because you are the expert in these cases. So what is your impression now when you look at the X-ray? How do you proceed, sir?
So with respect to this patient or these X-rays?
Both.
Both, okay. So with with respect to this patient has waxing and waning of symptoms. There are no consistent symptoms. They come and go. There is no fever. And this patient has radiological picture which is out of proportion to the clinical signs. And then there is all the reason for us to suspect multifocal non-infective lesions in this patient.
Yeah. So how do you proceed, sir? Further investigation. See, of course, MRI was taken, which showed inflammatory lesions in the tarsal bones and the femur. And after anti-inflammatory treatment, also there were the vertebral pathologies were continuing, and whole body MRI showed multiple foci of osteomyelitis, and the second picture, ankle, showing metaphyseal and epiphyseal lesions, and the third, left femur, shows involvement of diaphysis and soft tissues. So in such cases, you told it is multifocal osteomyelitis. Sir, what are the other things that we have to keep in mind in such cases?
Yeah. So tumors, like, blood neoplasms. So it is whenever we say non-infective osteitis or chronic recurrent osteomyelitis, it is a diagnosis of exclusion. Though we have Bristow's criteria, in each of these cases, we have to rule out an infection and malignancy. So we do a whole body MRI, and in this case, if you go back, everything fits into a chronic non-infective osteitis except for the left femur. You see a lot of soft tissue here, and here I will be suspicious and more and I will do a image-guided biopsy and aspiration from that soft tissue around the left femur and send it for histopathology and culture. Because very rarely this may turn out to be something else. Okay. So if there is a lot of soft tissue in a case of so-called chronic recurrent multifocal osteomyelitis, we will send that. But if that soft tissue level tissue did not exist, then I would treat it empirically as a CRMO.
Yeah. So CRMO is one of the conditions that we do come across often. In fact, in our hospital, we do see more patients, probably because of the referral, and we have a pediatric rheumatologist and a pediatric orthopedician also. So these are the reasons why probably we get more cases. So in this case, of course, the we cannot based on MRI. So neuroblastoma, as you told, was excluded. Technician bone scan was done, and epiphyseal lesion in the distal left femur was seen, and bone biopsy was performed, and it showed a lymphocytic and plasma cellular infiltrate and peritrabecular fibrosis. Immunohistology showed T lymphocytes, monocytes, and plasma cells, and that included the malignancy from the diagnosis. So, because and even the TB was ruled out. Of course, TB, I don't think it comes as a multiple lesions in many places. Am I right, sir?
TB can mimic anything.
Yes.
In India, TB of any area can mimic any pathology. So it's better to biopsy and culture that if there is a soft tissue shell, which has been done. I'm happy it has been done.
Yeah. Since the patient exhibited multiple bone lesions, recurrent course, biopsy consistent with chronic inflammation and no cultivable bacteria, CRMO was diagnosed. He was started with the naproxen. He developed allergic rashes. Ibuprofen. He started with some stomach upsets, intolerable. Then the rheumatologist told sulfasalazine, which is a disease-modifying agent, and improvement was noted, but he showed partial vertebral changes in the thoracic vertebrae. And later, because he could not tolerate all those drugs, then glucocorticoids for prednisolone was started. And with prednisolone, he became all right. But the thing is that he continued to have chronic stomach pain, and a colonoscopy was done, and that showed Crohn's disease, the histopathology. And he was treated as Crohn's with the multimodal anti-inflammatory therapy. And then now he is remission free. Why I brought this case is that one is because it may mimic, especially when the first lesion comes, it may mimic osteomyelitis. That is one thing. The patient has been treated as osteomyelitis in the initial period or septic arthritis. The second thing is that this particular CRMO condition, wherein there is a recurrent episodes, can be associated with other disorders. That is the point that we have to remember. And I have already discussed about the management. This is about the CRMO. So multiple sites of apparent osteomyelitis, pathology and cultures are negative, and no response to antibiotics. And generally, this CRMO can be associated with synovitis, acne, pustulosis, and hyperostosis. So this is in brief the pathophysiology. What I mean to say is that the defect in TLR4 or MAPK or inflammasome signaling cascade, that results in the imbalance between the pro and anti-inflammatory cytokine expressions in monocytes. And that is probably responsible for the pathophysiology. This is a beautiful article which in detail discusses about the CRM. And these are the radiological features. And I think the clavicle is a characteristic involvement. Am I right, sir?
Yeah. Clavicle, jaw, and forearm. If you see involvement of these three areas, you don't see them typically in infections, but you will see them in CR. Having said that, we had a child recently who had, clavicular osteomyelitis, and she was diagnosed as CRMO, but actually turned out to be osteomyelitis.
It is the other way around. Yeah. So usually the first episode may be confusing, sir. When it comes in multiple
it evolves. So by the time it reaches a rheumatologist or an infection specialist or orthopedic surgeon, already all investigations are done and the disease has evolved fully, and it's easy to recognize. Just one point I would like to add in this beautifully managed case is that whenever you have multiple vertebral involvement, addition of bisphosphonates is important because it prevents the osteoclastic activity and helps to maintain the vertebral spine.
I would like to ask one more question, sir. When you take MRI, what is the 1 point or 1 or 2 points that makes you, takes towards CRMO?
So the changes on MRI are much more, as compared to the clinical symptoms which the child has. So that is something which tells us that
It makes you think of,
this is
yeah,
more inflammation.
absolutely,
And
absolutely.
then typically child is good at sometimes playing around, he will go to school, and suddenly 2 or 3 days he will be completely sick. So there is no, if it's a TB or some other disorder or infection, all of us know that child is sick continuously. There is no waxing and waning of symptoms.
Thank you, sir. Thank you very much. So differential diagnosis, we have already, only thing is the SAPHO syndrome, SAPHO syndrome, which is described in adults, and the CRMO is supposed to be a pediatric equivalent of that. So that's why we do see associated things like Crohn's and etc. So, and as you told, the first line therapy is NSAID. The second therapy is biphosphonate. I think you have already highlighted on that. So we'll move to the next case. This is for Prabhas, his case. 8.5-year-old male, high-grade fever, 8 days, right knee arthritis, high counts, high CRP, treated with broad-spectrum antibiotics as septic arthritis. On examination, he was conscious, alert, not sick, too sick, well in between the episodes of fever. Total count was 28,000, CRP high 245. Knee joint tap 20,000, polymorphonuclear PMN 80%, polymorphs are 80%, and gram stain culture negative. And he started with cough, respiratory distress, and mild hepatomegaly and other things. This is the cardiomegaly, which X-ray, which shows cardiomegaly. And Dr. Prabhas, how did you, what are the thoughts that you had when you had this case?
So as we go to the case, the patient presented with a history of fever and arthritis. So when the patient presented with a fever and arthritis with high inflammatory markers, the first thing came in our mind that we are dealing with an infective arthritis. So it's a septic arthritis. You're receiving an antibiotic outside. You already started on high broad spectrum antibiotic here. Only one thing that was not matching, but it's a very subtle finding that usually in case of septic arthritis or septic patients are not doing well in between the spikes of fever. In this patient, the patient was quite sick during the spikes of fever or high spiking, 103, 104, but then it touches completely on the baseline and the patient was almost stable during the times of febrile period. But the first thought was that we are dealing with septic arthritis. So as by protocol, a knee joint tap was done and 20,000 cells we are getting and 80% neutrophil was there. So we're quite sure that it's a case of septic arthritis. So we started on antibiotic, MSSA, MRSA coverage. But on that, after some time, the few respiratory symptoms develop. You see this X-ray, chest X-ray, you can see that there is a bit of pleural effusion is there. There is a cardiomegaly. And when there's a cardiomegaly and we repeated the count, CRP, everything is elevated. ECG was low voltage, blood culture, no growth. Then the thing came in our mind that possibly this is a case of septic arthritis, MRSA, there's a pleural effusion, there's a pericardial effusion, so the disseminated staph infections. So we're getting some disseminated staph infections. So we are continuing on the same therapy, but at the same time, the one thing that clears the diagnosis is the appearance of the rash. So there was a rash, evanescent rash. You can show the picture of this kid on the rashes on the cheeks. During the fever count, the rashes started coming. And after 3 to 4 days of treatment, the kid started deteriorating. The count came down, platelet came down, CRP was high, rash was very much florid, it was fixed. I started having encephalopathy. We can see the same kid has encephalopathy, lots of bleeding spots here and there, coagulopathy. So this patient, initially, we thought of a case of MRSA, disseminated MRSA, sudden onset cytopenias, encephalopathy, coagulopathy. Then he started thinking whether we are dealing a case of systemic GIA with MASH, because we had an excellent and robust pediatric rheumatology unit. So the case has been referred to rheumatology unit and diagnosed as a case of SGIA, and we sent a ferritin. And this ferritin came as a sky high, it was 98,000. So it was initially mimicking like a septic arthritis, but actually it's a systemic GIA, and that went on developing MASH And encephalopathy, ferritin was very high and treated on methylprednisolone and improved. So the trick is that even in a inflammatory arthritis, you can get the synovial fluid count up to 20,000, 30,000, 40,000. Even seen a synovial fluid cell count as 50,000, and usually the PMNs are more. So this is a more misleading point, that when you are getting a 50,000 cell count in a fluid and the polymorphs are 80% with the high count and high CRP, suddenly we started thinking of septic arthritis. But in these cases, we need to think about that septic arthritis mimickers, that whether dealing as a systemic GI or not, we need to ask for the history of rash, any evanescent rash is there or not, the quotidian fever is there or not. So ultimately, this patient developed MASH and survived.
So thank you for that beautiful case. So we will go for the next case. That is a 6-year-old, fever, painful, swollen left ankle, 1 week, and gave ibuprofen, some relief, but findings progressed. Investigations normal, treated with the antibiotics with the suspicion of osteomyelitis. He seemed to improve and the left ankle swelling disappeared. 3 weeks prior to admission, he developed left wrist pain and swelling with fever. Bone scan increased uptake in the left radius, though the X-ray was normal. Again, another doctor gave amoxicillin oral, amoxiclav also, and then pain and swelling regressed. Developed pain tenderness in the right elbow. And on admission, he had markedly swollen tender right elbow. All other joints were normal. 2 lymph nodes were there, cervical, axillary. And laboratory investigations, WBC count of 7,700 and lymphocytes 72%, platelet 4.1 lakhs, and high ESR. And the radiology showed right elbow effusion with the normal bones. There was a metaphyseal destructive lesion in the distal left radius. Again, they thought of osteomyelitis because there was a prior response to antibiotics and NSAIDs. And this is the lesion, destructive lesion in the left radius. So 3 people have treated this as a osteomyelitis. So history and radiological suspicion that this might reflect a non-infective reason. So did a bone marrow which showed hypocellular marrow with about 90% blasts, and it turned out to be acute lymphocytic leukemia. He was treated and he is in remission. So the point which I want to discuss is that the child had shifting swellings, fever, joint pains, and some response to NSAID and antibiotics. The final radiological detection of a focal destructive lesion could easily be related to partially treated osteomyelitis. So that probably must have changed their direction. So in the point which we want to tell is that the intensive pain, atypical pattern of arthritis, anemia, leukopenia, or increased ESR in presence of systemic manifestations are important features to suggest diagnosis of underlying malignancy. So these cases, probably we should think beyond infections when there are certain things which are not behaving as expected. And I went through the literature. There was a paper, maybe little old, but osteoarticular manifestations as initial presentation of acute leukemias in children. So arthritis was about 26%. 26% of the patients had arthritis and limb pain, joint pains, arthralgia, etc. So we have to think beyond infections in such cases. So what are the pathways that to explain the involvement of joints in such leukemic patients? One is the leukemic infiltration. Second is intra-articular bleeding. Second, thrombocytopenia and synovial reaction. Third is deposition of monosodium urate crystal and synovitis related to the immune complex. And Ischemia may be due to the maybe the cause of bone restriction, because in infection also the purulent material can obstruct the metaphyseal vascular bed. So we have to be beware of the bone and joint mimics. So, sorry, Dr. Manish, this is for you. After end of this session, it is what it could be.
This is
X-ray.
probably some the diaphysis. There is some involvement of the diaphysis, and soft tissue surrounding is almost normal. So it's probably some non-infective osteolytic lesion. So probably some chronic non-infectious osteomyelitis.
Sir, your comment on the radiology, sir. Dharal.
Yeah. So, if if the symptoms are not too much, and with this radiological picture, we'll treat with anti-inflammatory and watch.
Thank you. Next. Prabhas, anything?
Yeah, this is a classical X-ray picture of infantile hyperostosis or Caffey's disease that is sometimes present with the swelling of the mandibles, and you can see. And they present with anemia and very high platelet counts. And the child sometimes present with just only excessive cry. And after some days of the cry, the swelling of the limb started appear. And is very commonly treated as a case of acute osteomyelitis with periosteal reactions. They usually beautifully responded to NSAIDs.
Thank you. Balivant?
Sir, there is a multiple lucencies around, and also
your voice is a little.
Hello.
Yeah, now it is.
There are multiple lucencies I could see in it, and also in the top there looks like there is a metaphyseal band, which is a typical of leukemia.
Okay, so this is again leukemia. So the point of showing these radiological picture is that we have to think beyond infections, beyond bone and joint infections. So Indian Academy of Pediatrics, we had a consensus statement on the diagnosis and management of bone and joint infections. And many of our friends are here who are part of this statement. And there is one European Society, ESPAD recommendations and IDSA. These are some good articles which throws more light on these recommendations. So to conclude, the take-home point is that suspect bone and joint infections whenever there is the clinical picture goes into that, fever and some restricted movements, pain, etc. Serial CRP is more reliable and inexpensive for the follow-up. Judicious choice of radiological test is very important. Sonography, of course, has a high sensitivity, and the MRI is the gold standard. Cultures have to be done, whether it is synovial or the blood culture. End point therapy, the normal CRP, asymptomatic or minor symptoms. The endpoint may be more difficult to determine in complex infections. Orthopedic follow-up, if available with the pediatric orthopedician or the general orthopedician, at the end of the course is very important, because the long-term things have to be seen. And we have to be beware of bone and joint infection mimics. So with that, I conclude this session. Thank you very much. Thank you, my panelists who have done a wonderful job. Dr. Balivant, Manish, Prabhas, and Dr. Taral. Dr. Taral Nagda, your presence has made a difference, and we have learnt a lot from these things. And you have made the things very simple, which is understandable. Thank you so much, all of you.
Dr.
Thank
Bhaskar,
you.
I just want to add one line. So
yes, sir.
when we take a symposium like this for orthopedic surgeon, we tell them that anything which is bone and joint infection cannot be treated by one person. So we say, as an orthopedic surgeon or pediatric orthopedic surgeon, it's wrong if I treat it alone. I must involve a team which includes a pediatrician and a ID specialist. So I think we have to have a team to attack these infections. and this strike team, which is made up of a pediatrician, ID specialist, and orthopedic surgeon, should treat the child together whenever you are suspecting a bone and joint infection.
Thank you, sir. Thank you. That is well taken. Dr. Bala, you have something to tell, sir?
Excellent. First of all, hats off to all of you. In fact, our orthopedic surgeon was fantastic. Dr. Nagda, I had an opportunity to share the dais with him. It's fantastic, very well done. And Bhaskar, expectedly, you had hit sixer after sixer. There is very little to score now. But having said that, it's customary for me to add a few points, salient points. I have just noted down like an eager student. Number one, in the initial discussion and in the later slides, Bhaskar, you had put that CRP is more useful for deciding the termination of antibiotic therapy and for following the prognosis. But I'm afraid there is much more to CRP in bone and joint infection than that. In fact, I always believe we pediatricians, we are obsessed with CRP for anything and everything, whether it is URI, LRI, pneumonia, everything we tend to do CRP. In fact, I shout at my PGs if they do CRP for V's, CRP for dengue, etc., etc. But I'm afraid amongst all the bacterial infections, one area where CRP is extremely useful, I'm repeating, extremely useful, is bone and joint infection. If you have a child who has what looks like an osteomyelitis and a septic arthritis, and the duration is at least 24 hours, if the CRP is less than 24 milligram per liter, it might actually be against infectious osteomyelitis. In fact, I'm yet to see Dr. Nagda, you can add, I'm yet to see a single case of septic arthritis or osteomyelitis with a completely negative CRP. So negative CRP has got a lot of value for ruling out rather than ruling in septic arthritis and osteomyelitis. Of course, it's customary to repeat it for de-escalation to oral antibiotics and for cessation. That's point number one. The other interesting point is about the X-ray in osteomyelitis or septic arthritis. In fact, I'm afraid an X-ray is a useless investigation in early osteomyelitis. I'm sure Dr. Nagda would agree. It only rules out other things like fracture, etc. It doesn't rule out osteomyelitis. It doesn't rule out septic arthritis. Am I right, sir, Dr. Nagda?
Yeah,
it doesn't rule out.
In a
That's
pure
one.
septic
Second
arthritis,
thing
it will
is
be negative.
often, yeah. And very important for pediatricians to ask for X-ray of both the limbs. There's no point in doing an X-ray of only one limb if you are looking for osteomyelitis. The reason is you should compare that limb with the other. So particularly in children below the age of 5 years, in fact, I remember in Children's Hospital, our radiologist, if we write X-ray left elbow and forearm, they will take both forearms and compare and then only give a report. So you should always ask for an X-ray both sides, not that it's going to cost much radiation, to compare. And one X-ray radiological sign, because it's outdated, it's an old sign, which I was taught when I was a postgraduate, is what is called muscle sign. In acute osteomyelitis, even if you don't have a swelling, radiologically you can see the muscle shadow more on one side. That could give a clue it could be osteomyelitis before bone changes occur. A normal X-ray does not rule out osteomyelitis or septic arthritis. And Dr. Nagda said that ultrasonologists would be able to distinguish inflammatory and infectious arthritis. Literature doesn't say so, doesn't agree on it. You can't distinguish unless you see strands of tissues indicating it's purulent. I don't think in early septic arthritis you can distinguish with an ultrasound between an inflammatory arthritis and a septic arthritis. Third, one of the differential diagnoses for the CRMO is multifocal tuberculosis. But I have had an opportunity to diagnose multifocal, proven to be AFB from everywhere. Ultimately, it turned out to be a gamma interferon receptor defect. So in immunodeficient individuals, multifocal TB can mimic your CRMO, and still rarely, children with disseminated tuberculosis may also have a reactive arthritis in TB called Ponson's disease. You may not get AFB, it will respond only to NSAIDs. And one of the clues to diagnosis of CRMO, in fact, whatever CRMOs I have seen, I'm honest in telling you, the third CRMO I saw, initially I thought it is malingering. Because child used to complain, in Tamil Nadu, we call a syndrome called KKK syndrome, Kai Kal Kudachal syndrome, limb pain. These children come with repeated episodes of pain, and they can actually be thought to have a psychiatric disorder in the early stages. That is dangerous. Of course, next 3 points, I'll finish quickly. One of the things which should never be done in early osteomyelitis, for example, day 1 of osteomyelitis or septic arthritis, we pediatricians or the orthopedic surgeons, we should straight away do an arthrotomy or an aspiration and then only start antibiotics. Otherwise, your yield in cultures will be very low, like pneumonia, less than 10%. And a new investigation which is revolutionizing septic arthritis and osteomyelitis due to unusual organisms, fungi, etc., is what is now developed as 18S RNA. From 16S RNA, they have moved to a new machine which does 18S RNA, which picks up organisms like Kingella and fungi in immunodeficient children. It's there in CMC Vellore. I'm sure it will revolutionize diagnosis where people have given antibiotics, cultures are negative. Last comment. When I was a student, I was always told osteomyelitis and septic arthritis, no oral treatment. Bhaskar, I'm sure you would have also been taught that.
Yes, sir.
That has changed. Oral step down in osteomyelitis and septic arthritis is very much the norm today. Outpatient and oral antibiotic therapy can be given. Here, common mistakes I have seen, orthopedic surgeons prescribing cephalexin, low dosage. Cephalexin dose can be as high as 150 milligram, 125 to 150 milligram, minimum 100. You can use in 2 or 4 divided doses. It can be used as a step-down therapy even in neonatal osteomyelitis or septic arthritis. Last comment is, Dr. Nagda put it very rightly, treatment of bone and joint infections is a team effort of pediatricians, ID experts, orthopedic surgeons, and microbiologists. Thank you very much.
Thank you, sir. Thank you for your valuable input, sir.
Dr. Bhaskar?
Yeah.
There are a few questions in the YouTube or as well as here, so would like to take up. Dr. Swapnil Usgaonkar is asking, MRI in osteomyelitis, does the contrast is required all the time?
Dr. Nagda?
No, not required. Not required all the time. Yeah.
Okay.
It's not necessary all the time.
Okay.
And we don't do routinely, no, sir, with the contrast.
No, we ask for a normal MRI. In fact, contrast is required if tumor is suspected, not if infection is there.
Okay. Then there is a question that since it is difficult to isolate organism in the blood in these particular cases, can we go for bone marrow culture?
Bone marrow culture is not that effective, but better to culture the tissue where the organism is.
Right.
The synovial fluid is more.
Get a bone culture and a pus culture from the joint. Blood culture yield will be definitely low. More so if you give antibiotics. Blood culture yield will not be high in septic arthritis except in infant. Older children, your yield. Other thing, I'm sure Nagda would have something to add. One of the clinical clues to Pseudomonas osteomyelitis is osteomyelitis of the calcaneum, which occurs following Thornburg, and it is notoriously due to Pseudomonas.
Absolutely.
One of the indications where for a bone and joint infection, I have used ciprofloxacin.
Right.
If you have a child with calcaneal osteomyelitis coming from a rural area, unless proven otherwise, it is calcaneal osteomyelitis due to Pseudomonas, in which you may not get the organism unless you do a bone culture. Pseudomonas is notorious. It can occur in immunocompetent. I'm sure Nagda would have something to add.
We had a couple of children I've seen, exactly same thing, not growing anything, not responding to any antibiotics. But moment you start them on anti-Pseudomonas antibiotic, they just respond like magic. Along with, of course, removing the thorn. If it's but many times the thorn comes out, but the infection, remains behind.
Remains.
Remains.
Okay. There is a question by Dr. Kamini Ashok. Exactly how many weeks for IV antibiotics in osteomyelitis? So just you can re-answer that. We have discussed it, but still, IV antibiotic necessary for how long in osteomyelitis?
So again, it's based on what bug it is. For example, MRSA, bacteremia is there. I think minimum 8 days of IV antibiotic is required, along with the clinical and laboratory improvement. The child has to improve clinically also, and the inflammatory marker like a CRP has to come down 30 to 50% below from the peak level. And minimally 8 days for the resistant bugs like a MRSA bacteremia.
Suppose the child is clinically stable and child's clinical the fever comes down, the other pain comes down, and the CRP is ready, then you can switch over to oral. Am I right, sir, Dr. Bala?
If the CRP is falling, you have given sufficient duration of IV antibiotic. Now, early switching to oral antibiotic is very much justified, very much justified. Even in neonatal osteomyelitis, oral switch is now acceptable.
So there is nothing like we have to give this many days of IV antibiotics. It's not whether you isolate the organism or don't. Many times you may not isolate the organism.
And fully clinically.
Then you go for clinic. So that is a better way to. Yes,
I
Dr.
just wanted
Nagda.
to add a very simple clinical point. In MRSA osteomyelitis, what happens is you diagnose it, you do the surgery, antibiotic is started, child is settling down. Most of these children will have some spikes of fever in the second week. And that is a response of the bone which is healing. And the child is otherwise doing well, the swelling is subsided, playful, eating well, but fever is coming. So if you have a MRSA osteomyelitis and if you get fever spike in second week, don't panic and unnecessarily do MRI and other investigation. It will settle down. And this fever is because of body response rather than infection, which is not controlled.
Okay. Dr. Bhaskar, you discussed the case of dengue. Followed by that, after dengue, there was the infection. So when there is a thrombophlebitis in the case of dengue, it is developing abscess sort of thing or cellulitis. Which antibiotic will be preferred empirically? Of course, after drawing a blood culture.
No, actually, after, of course, the blood culture is drawn. So we have to cover MRSA also. So we can start with either piperacillin tazobactam, or it, of course, it depends on the local epidemiology. Ideally, it can be piperacillin tazobactam with the vancomycin should be fine.
So straight away, we have to
Later
go.
we can, depending on the culture sensitivity, we can de-escalate.
Suppose we have a patient of dengue which is having long-term prolonged fever, maybe day 8, day 9. The counts are gradually increasing, maybe around 12, 13,000, which was maybe low. And CRP is also increasing around, say, in the forms 30s or 40s. And there is a cellulitis at the IV site. So does that require this much of hit early, hit hard, or you can get away without that also?
No. If there is definitive counts are high, CRP or inflammatory markers are high, child is sick, there is evidence of local inflammation, then we have to hit hard and then come down.
Usually in these cases of superficial pneumophlebotitis, if you remove the cannula and apply, and usually the fever comes down by next 24 to 48 hours. Even if after doing that, the fever is not coming down, the swelling is not being subsided, then you strongly suspect about these things.
So many times you feel that it is cellulitis is developing.
Exactly. The feeling is different.
Right. Okay. Then there's a question, will osteomyelitis improve fully in 6 weeks of therapy? Dr. Prasanna Betala is asking. Will osteomyelitis improve fully in 6 weeks of antibiotic
So there
therapy?
are two aspects. One is infection will get controlled. The healing may take a long time depending on how much was the damage. Sometimes an osteomyelitis which is treated with surgery and antibiotics, the infection will heal, but the sequelae of osteomyelitis develop. They develop sequestrum, involucrum, and then that in that case the process may carry on for around 6 weeks to 6 months. Some of them will heal early. So it all depends on the extent of damage which has occurred as a result of osteomyelitis.
Okay. Then there's a question, does any specific particular joint or a bone affection affect the decision of earlier surgical treatment, Dr. Nagda?
Hip is the most common and most dangerous because in hip joint, the epiphysis is intracapsular. So it is like, holding a neck, you hanging somebody. When you get osteomyelitis, when you get septic arthritis of the hip, it is hung to death. Whereas this will not happen in knee, shoulder, or ankle joint.
Okay. So there are few comments and I think question. Dr. Palani, you are on the panel. So can you just say, Dr. Palani Raman? He has put a few remarks that regarding organism culture.
Sir.
Yes, Dr. Palani.
Sir,
you can. Yeah.
Sir, Dr. Taral's experience with respect to the organisms cultured, because you would have seen plenty of particularly septic arthritis. Your experience with respect to the organisms.
Yeah. So the experience of all of us, I think, is changing every year. And what really counts is flavor of the year. So there was a time when, of course, staph was common, and in between, around 10 years back, we had suddenly gram-negative and candida being seen, but we don't see that so much nowadays. I think the today's flavor is MRSA, and most of the time, almost 50% of our bone and joint infections are MRSA involved. We hardly see gram-negative except in neonates.
Your comment about Kingella, sir?
Kingella, I have not seen, though we have looked for it. I'm in an institution where we actively look for it. We had a bone and joint sort of a meeting of our Pediatric Orthopedic Society of India, and everyone felt that if you're not seeing now, maybe after a couple of years or after 5 years, we will start seeing, because as a society, we are becoming more mature. And the presence of Kingella kingae is seen as, running parallel to the economic growth of the society. So, if we become a superpower, maybe we'll start seeing Kingella kingae.
Because in the institutions, usually they start mainly the cloxacillin along with the ceftriaxone mainly to cover the Kingella. So as an empirical choice, that is the norm in the institutions to start ceftriaxone for covering the Kingella. So that is the reason I was asking this question.
It's fear of unknown. None of us have seen it, but we do cover it.
The below 4 years, it is prudent to start ceftriaxone, not only to cover Kingella, but also to cover H flu and also pneumococcus. I think it's not wrong to start ceftriaxone with or without cloxacillin. Even in fact, ceftriaxone alone should be good enough. But it should cover Kingella, it should cover MSSA reasonably well, it should cover H flu, it should cover pneumococcus. So I don't think there is anything wrong in doing that. And of course, addition of cloxacillin with ceftriaxone, most Western centers, they have stopped doing that. They don't give both the drugs, they give only ceftriaxone. But they don't, if they suspect Kingella, they give ceftriaxone alone. and they may add clindamycin. Clindamycin has got an excellent bone penetration, is excellent against pneumococcus, is excellent against MSSA, but it does not cover Kingella. So you have to have a cephalosporin or a quinolone to cover your Kingella.
Yes. So, and Dr. Daral, any special comments about, expert comment about discitis?
Yeah, so discitis can be non-inflammatory. It can be inflammatory or infective. So many times you have inflammatory discitis following a disc surgery. Fortunately, disc surgeries are not common in pediatric population, but we have seen adolescents who get discitis. So an infective discitis needs debridement and surgery. A non-infective discitis can be treated with just rest and anti-inflammatory.
Yeah. So any chances of oral switch in neonatal septic arthritis?
Yeah,
So,
that Dr. Bala is on.
Yeah, it is very much, it's very much.
Sir, your Sir, voice is cracking.
Neonatal septic arthritis, you can switch. In fact, one of the few indications where you switch from IV to oral. Septic arthritis, osteomyelitis in newborn, you can switch down to oral therapy if the infant is stable and the falling.
Sir, can you switch off your video and talk?
Cephalexin milligram per kg is very much, many papers are there saying that it's quite effective in neonatal osteomyelitis or septic arthritis. Only thing is you can't do it very early, like 1 week. Maybe I would err on the side of giving 2 weeks IV antibiotic before.
Sir, Bala sir, hello. Your voice is cracking. So can you just switch off your camera, video?
Yes, switch it off.
Yes, no, it is still.
He's lost connection.
Anyways, Dr. Yevle sir is there. Sir, any comment?
The excellent session, as is. I mean, nothing less was expected from Bhaskar, and Taral's presence definitely added flavor to the panel discussion. Only a couple of points that very often neonatal septic arthritis is diagnosed late. That's an important thing that we all pediatricians and neonatologists must keep in mind. That baby who has fever without focus in a neonate, or who is not doing well, or where you suspect sepsis, extremely careful examination of all bones and joints it's extremely important. See, a frank septic arthritis anyone can diagnose, but the beauty is picking it up very early at the onset. That is one comment that I wanted to make. Second is, in India, we do see osteoarticular manifesto of brucella, especially in the regions where brucella is, like in Maharashtra, we see brucella into Maharashtra. So brucella is one thing. And Kingella kingi, maybe with the increasing use of molecular diagnosis, maybe our yield for this thing may improve, because Kingella is like your Haemophilus, is not an easy bug to grow. So that was another comment. And then we all must try and use the synovial fluid biofire panel little more often. That would definitely be of great help in improving our yield of pathogens in bone and joint infection. The synovial fluid panel, it is worth. In fact, we pediatricians have started doing that jugaad of using this synovial fluid panel off-label in some other body fluids. But the primary aim, what it is meant for, should be used by all pediatricians. That would be a great diagnostic aid. Otherwise, excellent presentation, and Bhaskar has been the in the driver's seat when we made guidelines for bone and joint infection in pediatrics. So nothing less was expected of him, and thank you, Taral, for being with us, and really this. And then finally, I would say now everybody would realize why I say that Dr. Balasubramanian is the ID expert of all the ID experts. It's
Well said. Well said.
It's a combination of experience, expertise, and wisdom that has come. You look at his hair. So that color of hair speaks of years of experience, and he's been. I mean, I would not say he's been fortunate, but he has seen, I would say, millions of pediatric patients, and that was, and on the background of very sound knowledge and expertise. So it's a pleasure listening to him and his comments, and hats off to him.
Yes, yes. We all agree. We all agree. I think we have all the ID expert on the floor. If anybody wants to pip in and give some comments, we have Dr. KR, Dr. Jaydeep, Dr.
Tarun wants to tell.
Yeah, one comment is we've spoken of IV antibiotic and oral antibiotic, like how BioFiber is the new kid on the block. Similarly, we have a local drug delivery systems. So there are molecules which are mixed with vancomycin or gentamicin, and you can put it at the site of infection, and they will continue to release the drug locally for a period of 3 months. And this may be a game changer for future for a case of osteomyelitis which are operated. The amount of drug which you have to give parenterally, the duration may come down because of a local drug delivery system.
One comment that I wanted to make was, when it comes to treating MRSA, Taral, what is your drug of choice?
I leave it to our ID specialists.
ID
We do our job and they will.
Yeah. Why I raise this point is linezolid has an excellent, it's a good agent, because vancomycin, you have so many difficulties in administering vancomycin, and linezolid comparatively is a good drug. And we pediatricians generally are scared of using linezolid in non-tubercular indication. But as Dr. Chitkar once commented, that while we understand that linezolid should not be abused, but where indicated, it should be used.
Only thing, it's bacteriostatic. That's the point which limits it.
By and large, a gram-positive infection in an otherwise immunocompetent child, it really doesn't make much of a difference.
Right.
Dr. Bala may agree or differ on this.
You're right. See, Dr. Nagda, the concept of bactericidal antibiotics being superior to bacteriostatic is completely gone. It doesn't make any difference. You know the PK/PD of the drug and you use it. You don't worry about whether it is bacteriostatic or bactericidal. And linezolid is good enough even for bacteremia. I don't think it's inferior to vancomycin. Only thing is, you must have proof that it is MRSA.
Yes.
That's all. Without proof, without growing the organism in the culture, either in the blood or in the bone or in the joint, if you are using linezolid, that's incorrect. But if you are growing it and you want to discharge the child with oral antibiotic, there is nothing like linezolid. And the other alternative, probably safer alternative, cheaper alternative, is clindamycin, provided your lab gives you sensitivity report to clindamycin. Clindamycin is also bacteriostatic, but you don't have to worry about it. Once you are given good IV therapy for a week or two, you can only de-escalate, switch to oral bacteriostatic agents and get away with it. I don't think there is any problem at all.
One final thing that, I would like to share this experience and case that I saw about 10 days ago. This child was discharged yesterday from Apollo. He's a 5-year-old child who presented with swelling on the dorsum of the foot. And it looked like inflammatory, deep tissue abscess. It was sitting on the tarsal bone. And then not that it is extremely rare, we do see osteomyelitis in the long bones of the feet, the metatarsal, etc. So we got a sonography done which showed soft tissue shadow and collection, which was not, absolutely liquefied on first sonography. And my question to Taral is, do you agree that we must have a very high index of suspicion and low threshold for asking for test like MRI, because osteomyelitis is something that needs a different kind of therapy and duration and the choice of antibiotic. We got an MRI done, and it showed the bones and joints were clean, but there was a reactive fluid in the joint, so tarsometatarsal joint. And so, I mean, is it likely to miss out or confuse this reactive fluid and between the reactive fluid and a true sepsis, which has occurred because of the close vicinity of the deep-seated abscess sitting on the bone?
So MRI will have both roles, positive predictive role and a negative predictive. In your case, it showed that the bones did not were absolutely
Correct.
fine,
Yeah.
and that allowed you to treat it more conservative.
Yeah. But again, I mean, would you agree that whenever in doubt, you go ahead and be aggressive on diagnostic front? Like my teacher would always say, if you have all the CSF reports as abnormal report, that means you're not doing enough number of CSFs, number punctures. So similarly, bones and joints, whenever in doubt, be a little aggressive and don't take a chance.
Yeah. Dr. Dhanalakshmi, anything?
Sir, only one query, sir. What about the role of trimethyl sulfamethoxazole in MRSA infections? But actually, it is approved. Stanford guide says if it is sensitive.
Yeah. We see two things. Whatever data that is available, correct me, Dhanalakshmi, I'm sure you will be more updated than me. Cotrimoxazole is as good as any of the other MRSA drugs, provided there is no bacteremia. If there is bacteremia, cotrimoxazole is not recommended today. But if there is something like osteomyelitis, if you have good sensitivity, if you don't have any other alternative, cotrimoxazole, excellent drug, and the PK/PD of oral cotrimoxazole suggests that it's very well absorbed. You can use a high dosage at 10 milligram per kg, and you can treat, provided you have lab proof of sensitivity, provided you don't have any history of sulfa allergy. But studies have shown when there is bacteremia, you can't use either cotrimoxazole or even, doxycycline also has been found to be good for MRSA in few cases. Again, bacteremia is there.
Minor infections only, doxycycline.
No, they have tried it even in, invasive abdominal infections and got away with it. So if you don't have bacteremia, if you don't have allergy, cotrimoxazole is an excellent secondary choice for MRSA. But definitely when it comes to the gold standard, it's always preferable to use a specific MRSA drug than the secondary drugs like doxycycline or your cotrimoxazole.
The problem with linezolid is we need to give it for 4 to 6 weeks, then we need to monitor the counts also.
Agreed.
So definitely CBC has to be monitored.
But the bone and joint concentrations are very high, both with linezolid and clindamycin. That's a great advantage.
Yeah, thank you. Now, Dr. Darur sir, Chairperson sir, your comments, and then we will end the session with Dr. Yashwant Rao. Unmute, sir.
Sir.
Yeah.
Yes, am I audible now?
Yes, sir.
Yeah. See, all the principles and the take-home messages given are very nice and should be adopted. But one more should be added. All the cases that come to any children, they should come first to the Department of Pediatrics. From there, they should go to other departments depending upon their complaints. Otherwise, they diagnose and they don't refer to us back, or that there is a call is there, a younger person will go and cannot detect this, what Yavalevars are saying, that detection of septic arthritis in newborn is problem, infant is problem. This is due to the lack of experience. So all the cases that the orthopedic department wants to take an opinion should be seen by the professor or the senior most person, because for the last 6 months we are this principle to all the departments, and we are able to identify 4 cases of septic arthritis in newborn and 1 case of in an infant, and half a dozen cases of post-trauma post-osteomyelitis of tibia leading to knee joint septic arthritis. So this is the principle which has to be adopted of combined effort and combined investigations of osteomyelitis. It is the technician scan that helps more. If I am right, I may be corrected. Otherwise, this is the technician scanning will be done, which can give you correct answer, correct location also.
Thank you, sir. Now, it was a really excellent session, and I would request Treasurer Dr. Yashwant Rao to thank all, and let's close the meeting.
Good night, everybody. So we had a 2 hours marathon session of experts after our session, followed by our experts, Dr. Balabsubrahmanya sir, Yevale sir, and final comments. I thank Bhaskar Shanai sir, our moderator, for compiling wonderful cases. Then Balivan sir, then Manish Mehta, Prasun Giri, and lastly Taral Nagdal, the orthopedician, for his wise comments and inputs to our pediatric fraternity. I thank all the participants who have shared and put right questions to our panelists after the session. Thank you one and all on behalf of team PIDA.
Thank you. Thank you. Good night. Good night, everyone.
Good night.
Good night. Thank you very much. Thank you.
Thank you.
Thank you, Dr.